Hi everybody, it's Mike here from TwoDads UK. Thanks again for continuing to join us with our COVID-19 support sessions. Today is an episode that I'm really looking forward to because it features one of the leading consultants, obs and gynae and specialists in reproductive medicine, in my opinion, who works at the Lister Fertility Clinic. That is James Nicopoullos, who is the clinical director at the Lister. Bit of background into James for those of you that haven't heard of him. So he completed his obs and gynae and subspecialty training in London. And this is the pronunciation bit now. He completed an MD research thesis on the effect of sperm aneuploidy and DNA fragmentation on ICSI outcome. Wow. He's also widely published in other areas of assisted reproduction, such as management of viral positive couples, ovarian hyperstimulation, and management of poor responders. He also manages to have a little bit of free time as well. And when he does, he's spending that, I hear, chasing after his 12 and his 10-year-old son's tennis ball. And unfortunately, this man has an obsession with Arsenal. I won't hold it against him. Welcome, James. How the devil are you?
Thank you. I'm very well, Mike. How are you? It's a really unfortunate obsession.
Yeah. It is, but it's fine. It's fine.
And you pronounce my name beautifully as well.
Did I?
You did, yeah.
That was another area that I was thinking, oh, there's two words in this intro that could go horribly wrong. One was related to sperm and one was your name. So it's
you couldn't get rid of not saying my name though, so you did all right.
Yeah, true. Look, thank you so much for giving up your time. And I'm sure in a moment you're going to be telling people what your amazing team and clinic are doing at the minute, because you are in the thick of it. And so thank you, because I know your time is super precious at the minute. So I've got a number of questions. We're going to jump straight in. We've got 15 minutes in total, 13 minutes left. So we wanted to talk specifically to you about the guidance that is forever moving. So talk to us about the current HFEA or BFS advice to patients, please.
I think it's pretty clear. I think we went through a phase where every day there was a guideline. I wrote something to our patients and it changed, and we were ever changing. I think we've got to a place now where it's pretty consistent from all the professional bodies, the BFS, the Americans, the ESHRE in Europe. And as of mid-March or so, at varying speeds, they basically told us all to stop any new treatment cycles, to safely finish off the cycles we were doing, and to stop initiating any new cycles. I think it was a combination of factors, just to ensure we were being socially responsible in terms of social distancing, which we knew was going to be coming, to take the pressure off the NHS and the public health services, and also to a certain extent, there's a lack of information out there in terms of some of the impacts of the virus. So I think everybody was choosing to be very sensible. I think, I know one of the questions that you were going to ask was about the differences, and I think that in general they were very similar. The only real difference was that the Americans and the Europeans were pretty clear that they recommended perhaps not putting embryos back in people at the start of this, whereas the BFS and the Royal College of Obstetricians were very reassuring about the impact of this virus on pregnancy. So they were less prescriptive. So they allowed us the choice. And what we did when we finished off our cycles was offer everybody the opportunity to either freeze their embryos if they wanted to, or to transfer them, because we were reassured about the safety in pregnancy. But obviously with the social distancing, with pregnant women initially being in that high risk group, we wanted to give people the option, but most people did transfer.
Okay. That probably comes on to the next question then, in terms of had there been any conflict with the guidance from ESHRE and ASRM, the Americans? Was that the main one?
Yeah, that was the main one. Initially, I think ESHRE were the first people to say stop everything, and then the Americans were 2 or 3 days behind. I think the BFS, the British societies, were really sensible, and they basically said at the start, be aware of where we are, carry on safely while you can. But again, come I think the 18th of March, when the government had set the social distancing measure, included the pregnant women in that high risk group, we just were slightly later to do it. And interestingly, what I read last night when I was looking at some stuff is that we actually recommended stopping treatment the same day as Italy did. So although we were 2 or 3 weeks behind them in terms of the impact of it, we're obviously a lot quicker from a fertility perspective to put in these safe measures.
Wow, impressive. So in terms of what's happening at the Lister currently, I guess to ask when you think you'll be operating normally again is just ridiculous but what comfort can be offered?
Well, I think that the comfort that can be offered is that we're desperate to start for our patients. It's what we do well, although we're making ourselves really busy, and I will come to that maybe in a bit. We're desperate to get cracking. And I think the good thing is that we've moved from a period where everybody was talking about when we stop to now everybody's talking about where we start. The Americans like a task force, and they set up a task force. The Europeans are calling it a working group, and the HFEA are working hard, I know, to set out criteria that they think we have to meet to safely be able to restart, making sure it doesn't affect social distancing, the NHS. So I think everybody's desperate to find a safe way of starting. And that's kind of consuming our conversations as well in terms of how we safely start, what measures do we put in place in the clinic to change our practices, to reassure ourselves and the patients that it is going to be safe. That's a really good question. I think I'm hoping that some of the social distancing measures will be eased in 2 or 3 weeks. So it may become easier to get people in to start investigating. Because again, the HFE at the moment has said nobody should even be in the clinic from a fertility point of view, apart from cancer patients. But hopefully that will begin to ease in a few weeks. And thereafter, as soon as the HFEA give us the green light, and I think there will be some pressure on the NHS, on the HFEA from clinics to do that, we'll get started as soon as we can.
Okay. And I guess a couple more questions that I'm keen to. One is before we'll finish with what the Lister are doing currently, but I've seen something which is raising a lot of anxiety, and that's obviously from women that are maybe of a particular age, and they're worried that this 3 or 4 or even 6 months out of their year is going to have a negative effect on their overall net fertility. What comfort or does the Lister have any specific data that they can share with to give some comfort to these women?
Yeah, it's really difficult because we always have to be conscious of telling people that age is important and an egg reserve will go down with age, but at the same time we don't want to cause panic when it isn't there. And I think this, people often go through a real process and a real journey to get themselves to a point where they want to have treatment, and suddenly not being able to is horrible. And it's about not being in control of the whole process. So it is really, really hard, which is why things like this podcast and the support that you guys are offering is amazing. But I think we can hopefully give a little bit of reassurance. We are incredibly geeky when it comes to data, which at times like this is quite useful. So I had a little look, and just to give you an example, if you were to have an IVF cycle at 30 and put an embryo in, your success rate is 49% over the last decade here in terms of baby. If you were to wait a year, an IVF cycle at 31, the success rate is 48%. So at 30, a 6-month wait, and hopefully it'll be less than that, isn't going to massively impact on outcome, if at all. The same thing at 35. If you have an IVF cycle at 35, it's around 40%. If you wait a year, it's about 38.5%. So again, it drops, but a 6-month wait may drop your chance of having a baby by less than 1%. As you get a little older, it has a little bit of impact. But even at 40, if you have an IVF cycle at 40 over the last decade and put an embryo in, the success rate is around 26%. If you put an embryo in a year later at 41, it's 21.5%. So if you look at it, a year may drop your success rate by about 4.5%. So 3 or 4 months, yes, it may drop it by a couple of percent. but I'm hoping that reassures people it's not going to suddenly drop off the end of the cliff. And it will be different for different people with different egg reserves, but the trajectory, it's not going to suddenly do that. And I think what's key that we do, and other clinics hopefully are doing, is that when we do restart, we obviously have to prioritize people who are waiting, but also prioritize people with the biggest clinical needs. So those people who have got a lower egg reserve, or perhaps who are at an age where the delays had an impact, we make sure we start these people quicker. I think that's going to be the key.
Yeah. That I guess was something else I'm sure a lot of people are worried about, is how will I be prioritized when we're in this new world or new normal. So great day.
What we're trying to do is, we're sending sort of email updates to all our patients every 10 days or so, trying not to bombard them, because I think, they don't want to be emailed every day by anybody. But we've also got a little database of everybody who was delayed, or everybody who I think needs to start, and I'm actually sending them an email later today to say, look, be reassured you are on this priority list. I don't think we'll have an issue with capacity, but I just think, you need to be reassured.
Perfect. Amazing. Thank you. And tell us what you guys are doing at the minute, because I know the Lister are doing some incredible stuff in the NHS currently. Tell us. Yeah,
we're trying. As you know, we're in a existing hospital. We're not standalone units, so we're part of a HCA as an organisation, which is working with the NHS to support them. So all the HCA hospitals are taking in NHS patients. Thankfully, I'll be honest and say, the NHS is coping, very well, despite how obviously crazily hard everybody's working. So we haven't needed to take the number of patients as the hospital in, because local hospitals are doing so well. But as a clinic, we've taken on all the early pregnancy emergency work from local NHS hospitals just to take that burden off. It's using our expertise. It's stuff that we do well. A lot of our nurses are being taken up to the ward to cover general patients, and they've done that happily. A lot of our embryologists have retrained as healthcare assistants. They volunteer for the Nightingale. I think one of my colleagues is over there today, being interviewed. I'm just desperate. Wow. I'm just desperately hoping we can get them back when we need them, though. But I'm sure we will.
Yeah, I'm
That's
sure.
Good stuff.
I'm sure. Incredible. Okay, so then before we finish, we've got a couple of minutes left. Then, can you give us your top tips of working within these unprecedented times, with patients? So fire us over some of your tips.
I think the other thing I was going to say, actually, in terms of what we're doing, kind of ties in with tips, really. I think we all need to talk to each other. I think we need to communicate with people. I think we need to be there for each other in terms of, be it from a fertility perspective, be it on the end of a phone to your mate perspective. These are difficult times for everybody. And certain things, be it live alone or fertility, can heighten that. What we set up actually at the end of last week was a support hub. All our counsellors are working hard. It's something that all our patients can access whenever they need, without paying for it. I think we're opening that up this week to patients who aren't Lister patients. I think that's important. I think we've got a direct phone line that people can call in and just ask queries, because that's people have got questions. When can I start? How am I going to start? How is this affecting me? Yeah. So I just would say stay in touch, and whether it's us or somewhere else, stay in touch with the clinic. Just be aware of when they're starting, and I'd also say be aware that we might all be starting in a way that's different to the way we were before, because we'll have to see patients in a different way. We'll all be doing more video consultations. So I think everybody will have to just be aware that things, be it from a IVF point of view or a world point of view, are going to be different for a fair while.
No, that last point in particular, I think that's what we all need to get used to, is that there will be a new what will be, and it's going to be a bit new and a bit different. And I'm
hoping this makes us all nicer, kinder, friendlier people. I'm hoping that's going to happen at the start. Let's hope it lasts. So I worry about us all being really appreciative of stuff for 6 months and then not much later. But let's hope it all lasts.
Well, let's make sure that happens. Look, James, you've been a gem. Thank you so much for joining us. Keep up the amazing work. Thank you so much for everything.
Amazing stuff.
Thank you. Appreciate it. Take it easy.
All right, see you. Bye.
Thank you. Cheers. Bye-bye, mate. Bye-bye.
Bye.